Hi everybody, this is Dr. A. Alright, this video is going to be over therapeutic drug monitoring. It's chapter 33 of Larson's Clinical Chemistry. Alright, so why do we do TDM testing? So this is for therapeutic drug monitoring, and we check blood levels of the specific drugs that are being monitored. Now occasionally students can get confused thinking, for example, we monitor thyroid drugs in a way because we check the thyroid levels to make sure that the thyroid therapy works, but that would not be considered TDM. Okay, so TDM is when you measure specific levels of a drug that is given to the patient to check that they are in the right range, in the therapeutic range. And because it is really important for the specific drugs to maintain the right amount, because the window of efficacy to toxicity is really small. So, and these drugs, obviously, if they don't have enough in their system, they're not going to have the therapeutic effect. But if there's too much of the drug in the system, there will be a toxic effect. And the jump from therapeutic to toxic is just really small. And another reason that these need to be monitored is because the response to drugs can differ in people. There's so many things we're going to look at that can vary from one person to the next. And so, with therapeutic drug monitoring, you can use these lab results with the patient's clinical information to get the best drug and dosage to work to control whatever the condition is that needs to be managed or controlled. So on that, think of what is an example of a drug that would require therapeutic drug monitoring and what is one that does not. For those that does not, for example, anything that's sold over the counter, it's obviously if it's over the counter, it's super safe, and so it would not require TDM. So let's talk a little bit about drug disposition. So the drug's mechanism of action is directly related to its pharmacologic effect at the target area. Some drug mechanisms are still unclear. So, for example, did you know we don't exactly know how acetaminophen works, how Tylenol works? Don't know. It's on the market, it works, we know what it works for, but the biochemical mechanisms are still unknown. There are some theories out there, but all right. Therapeutic drug monitoring does assume that the size of the pharmacologic effect is directly proportional to the amount of drug at the target level. And so, yeah, the more the target level, the more the pharmacological effect is going to be. But of course, there can be some variations there from people to people. So the therapeutic range, so this is not normal range because normally people don't take these drugs. So this is why it's called therapeutic range. So the bottom number of the range is going to be the minimum effective concentration, meaning for the most people in the population, they need to be above that level to see therapeutic benefits. The top number of the therapeutic range is going to be the minimum toxic concentration, meaning this is the lowest level at which you can start seeing toxic effects, and you definitely do not want to go over that level. So now let's talk about a couple other concepts, pharmacodynamics and pharmacokinetics. So pharmacodynamics is the study of the biochemical and physiological effects of a drug and their mechanisms of actions. So it's basically what the drug does to the body. What receptor does it bind on? What process does it turn off, turn on, enhance? Like what does it do to the body? Okay. The pharmacokinetics assesses the rate of absorption in distribution in biotransformation, excretion of the drug. So it's what the body does to the drug. So how the body moves it along, how the body absorbs it, how does it circulate it, how does it detoxify it, how does it clear it from the system. Okay, so that's pharmacokinetics. Okay, and there are a lot of factors that can influence the pharmacokinetics of a drug. So just think kinetic moving, so how it moves through. So there's things, for example, the patient's history, and if they're taking other drugs, so that could affect absorption, distribution. It could affect biotransformation if they're being detoxified by the same types of enzymes. And how the drug is absorbed also can directly affect the pharmacokinetics, as in, is this something that would be orally taken? Is it inhaled? Is it topical? Is it injected? Like, what's the difference there? How it's distributed, metabolized, all of these things, and these things can vary from one person to the next also. And so, again, what the body does to the drug, how it moves along, meaning everybody's body is slightly different, and so these processes could be different. Okay, so so if a TDM drug level is outside of its therapeutic range, assuming the correct collection and timing, what would the potential side effects be? So either not enough of a therapeutic effect or too much of an effect to the point of being toxic. So that's, of course, going to be either one, because if you're outside of range, you're either too low or too high. Okay, so again, the pharmacokinetics is how the drug moves through the body. So this is going to be directly related to the dose. The dose is going to be related, of course, to the size of the patient, and that the size of the dose is going to also relate to its bioavailability and how much hits the circulation and how much hits tissue. So that's distribution. And then also how it gets excreted and cleared from the body. So how is it moving through all the compartments of the body, etc. Of course, the ultimate goal is, as it reaches the circulation and travels through the body, is to reach the site where the therapeutic effect needs to happen, and that effect happen. But then, and at that site, then you have the pharmacological effect. And so this is the effect on the patient. So for example, does that drug work for that patient? This is where you can start seeing individual variability. I don't know if you guys have experienced this, for example, with, I know like in our family for like Benadryl, which is just a typical antihistamine you can buy over the counter. So like, if I take it, it does very good to control allergic reactions and stuff, but it will always make me sleepy. Okay, so I have the sleepiness, which is what most people will have this effect. But in our family, like my youngest brother, you give him Benadryl, especially when he was a kid, that kid would be just bouncing off the walls and would hype him up. So it has a different pharmacologic effect on different people sometimes, even though it does control the allergies. Like there's some other effects there that are different. And so the pharmacologic effect on the patient, if it's too much, you'll have toxicity, and you want to make sure that there's enough so you have efficacy, so it's working, and you have the proper clinical response. And having a good clinical response then means good clinical utility. So for example, there are several seizure medicines out on the market. They all have specific kinetics, and they can all reach the effect site, but one drug may control seizures better in one patient than another drug, but you go to a different patient and they need a different drug or a different dosage to control their seizures. Okay, so a little practical application of that. So for example, the statement, ibuprofen works by binding the COX-2 example. COX-2 enzyme, is this an example of dynamics or kinetics? So remember, dynamics is the effect on the patient. The kinetics is what the body does to the drug and how it moves and stuff like that. So think about that and try to answer. You can always go back. And this one, patient A needs 3 times more sedatives than patient B to get appropriate sedation. This is an example of pharmacodynamics or pharmacokinetics. Again, so remember the effect on the patient, the effect on the patient or what the drug does to the body is dynamics, and kinetics is how the drug moves through the body. All right, so absorption of the drug. A lot of drugs are given orally, so they're pills that you have to take, and so they would dissolve in the GI tract and enter the blood, and it usually goes straight to the liver because you have the hepatic portal vein, the portal circulation, which links the GI tract straight to the liver. Okay, And so everything that absorbs goes straight to the liver, and the liver starts processing and detoxifying things. And so for an orally administered drug, of course, then you would need a dose high enough that it can basically survive this, what we call this first pass, which is the absorption from the GI tract going straight to the liver, so that it can actually reach systemic circulation and go to the site of action and have its effect. And so these absorption rates can be influenced by the drug formula. Is it a rapid release formula? Is it an extended release formula? Is it a pill that needs to be dissolved into your fluids, GI fluids, or is it a liquid that you're drinking? You know, so all kinds of things here can vary. The GI motility. So in this case, you know, how fast are things moving through your system? If a person has diarrhea, then the drug could be moving through too fast and therefore not have enough of a chance to get absorbed, and you would have not enough of the drug in the system. GI diseases, such as a lot of the inflammatory bowel diseases, would interfere with the proper absorption. So when you have inflammatory bowel diseases, a lot of nutrients aren't absorbed, and drugs aren't absorbed as well because of the presence of the inflammation in the gut wall. Certain foods can interfere with the absorption. So grapefruit is an example of foods that can block the absorption of certain drugs, and it can enhance the metabolism of others. So grapefruit is kind of screwy on drugs. And for sure, if there's a drug that gets interference from grapefruit, there should be a label on the bottle that says so, and say avoid taking with grapefruit juice. Okay, so if your patient is on digoxin and they develop a severe case of diarrhea, what would you expect his digoxin levels to be? So you think it would be below therapeutic range because of the diarrhea, or above therapeutic range because of the diarrhea? So think about it this way. Again, what happens with the diarrhea, and then answer for yourself that question. Okay, so bioavailability is the fraction of the dose that can reach the systemic circulation. So for, again, orally administered drug is whatever can survive first pass through the liver and actually hit systemic. And so this is a big factor for orally administered drugs. Okay, again, not only how much is absorbed, but how much survives first pass. And their bioavailability is always less than 100%. And so the dosage of these drugs, especially over-the-counter drugs, do take that into account. And of course, it also depends on the drug formulation, whether it's immediate versus sustained release. Of course, it is less of a factor for IV and inhaled drugs because you pretty much get them straight into the systemic circulation, and so their bioavailability is usually there 100%. So the distribution is going to be the process of moving the drug from the site of absorption to the other areas of the body, and hopefully where the drug is needed. So the dosage per kilogram of weight can affect the distribution, and of course, this is where dosage in a lot of these medications, dosage have to be specific to the size of the person. You know, the dosage for an infant is not going to be the same as for a teenager, and even for a teenager, it kind of depends on the size of the teenager, right? And so that's why we go by kilogram of weight versus specific age. And then you have to have receptor availability. So if this drug is meant to bind on a receptor, then how many of the receptors are available are there to bind the drug? That there's an individual variation in this, of course. And so for it to be properly distributed, it also needs to be able to reach the proper receptors. So in the distribution of free drug is what is available for distribution for that's really bioactive. It's the active form of the drug that can have the therapeutic effect. But we have limited testing available for free drugs. The bound drug is bound to protein, and so acidic drugs will bind to albumin, and alkaline drugs will bind to globulin, but either one, and so they're bound to protein. If they're bound to protein, they're not active, right? They have to be released from their protein in order for them to have action. And so, again, all of that dosage can take all of that into account. So most of the time when we do analyses on specific drugs, then we really do total levels. So it would measure free and bound drug levels. Disease states and physiological changes will affect the distribution, again, because it can affect so many phases of it, and it could be whether or not how fast you detoxify, if you if you're fast or slow metabolizer, if what's your heart rate, how fast are you circulating blood, and are you dehydrated, or again, there just so much things that can have affect this distribution. And the distribution in the brain and spinal cord, a lot of drugs can't reach that area because they have to be able to get around the blood-brain barrier, and some are just not able to do that, or they're too big, they just can't cross over. And so if you need that drug to reach that site, it has to be able to cross the blood-brain barrier. So give an example of what could affect the distribution of a drug. So metabolism and biotransformation. So you have to understand that when we take drugs, prescribed drugs, things that are given for therapeutic reasons, the body does see them as chemicals that do not belong. They're not a nutrient. They're not a carb, a lipid, or protein. They are not a vitamin. They are not a mineral. They don't really have a function in the physiology, if you will. And so your liver, what it's going to do is, if it recognizes this as a foreign molecule, is it's just going to try to detoxify and get rid of it. So the liver is a principal organ for drug metabolism. That's what it does. And the variation in a person's genetics that's related to drug metabolism is known as pharmacogenomics. So this is where we can look at differences in how much of the enzymes that do all of these detoxification a person has. There are genetic variabilities, there are some mutations, there are all kinds of things that can affect how a person metabolizes certain drugs. So currently we have very limited availability testing for pharmacogenomics. Coumadin is one of them that is available, and this test will identify slow versus fast versus normal metabolizers, okay? Meaning that a slow metabolizers will need a different dose than a normal metabolizer versus a fast metabolizer, because of in a slow metabolizer, the drug hangs around longer. Fast metabolizer might need a larger dose of the Coumadin because it clears the system faster. Okay, so biotransformation is that conversion of the potentially harmful chemicals into inactive metabolites. So this is what the liver does. And so there are two ways, or two types of reactions, and this is based on how enzymes work. Some of the drug metabolism can be done in first-order kinetics, where there's a linear relationship, and meaning the more of the drug or substance is there, the substrate for this enzyme to work on, the faster the enzymes work, the faster the reactions go. And so in first order, metabolism is proportional to the drug concentration, and drug elimination is adaptable. And 95% of the drugs will fall under that category. And so this can also be a thing if you have polypharmacy, if you have people on several and all of those drugs are in metabolized in first order kinetics, they may clear them faster than if they were just on one. Zero order kinetics is nonlinear, meaning the rate of metabolism is independent of the drug concentration. So more drugs does not make the body metabolize it faster. It just kind of has more of a constant rate of metabolism, and it does also, of course, depend on the amount of enzymes and things that are contained in a person's liver. Ethanol, which is alcohol, and phenytoin are both eliminated in a zero-order kinetic. So you can't speed it up, it won't metabolize any faster. Okay, so the cytochrome P450 enzyme family are the ones that metabolize most drugs. And again, the profile of what an individual has, how many variations and all the things in these enzymes, there's a whole family, there's a bunch of them, right? This can affect drug-drug interactions, especially if they're both competing or both being metabolized by the same family of enzymes or same enzyme. So it could slow the enzymatic detoxification, or it could boost it if there's polypharmacy, if there's multiple drugs there being taken at the same time. It can also affect food-drug interactions. So, for example, alcohol can compete with other drugs for metabolism. So alcohol and phenytoin could compete for metabolism. Some drugs that pass through the liver will be converted to the active form. So this is true for procainamide and NAPA. And the metabolites are the ones that actually have the therapeutic effect. So most drugs, it's the drug itself that has a therapeutic effect. The metabolites are just inactive and just have to be cleared. But procainamide is the one where the drug itself, the procainamide, is inactive. And when it passes through the liver, the metabolites are what actually gives the therapeutic effect. Okay, next little question for your consideration. What would be the danger of taking a sedative or a pain med with alcohol? So think about that for a minute. All right, excretion. Some drugs are totally cleared by the liver, and meaning that the liver detoxifies them and then they get dumped into bile, and then bile gets dumped into the GI tract. The clearance factors that affect this excretion are going to be the free drug concentration, so how much of the free drug was in the systemic circulation, how well the liver works, right? Do they have, fatty liver disease? Do they have hepatitis? Or do they have cirrhosis of the liver? Are there problems there? Are there any enzyme inducers or enzyme inhibitors that are present that would affect the metabolism of the drug by those CYP450 family of enzymes? So after they are metabolized by the liver, the metabolites are going to be excreted because they've now been rendered harmless. So anything that's water soluble is going to be cleared by the kidneys. So meaning the liver will put the metabolites back into the blood, and then the blood is going to pump in. These metabolites will reach the kidneys and can be excreted. Anything that's lipid soluble ends up in bile, and then bile ends up in the GI tract, and then it exits via feces. Anything that's volatile can exit also by the lungs. And so this is, for example, alcohol. So when a person is drinking alcohol, of course, a certain amount is being detoxified by the liver, but there's some of it that's being actually breathed out. You can breathe it. You can feel it on their breath, which is why you can do breathalyzer tests to estimate the alcohol concentration in the blood. Worth noted that drugs can also be excreted in breast milk and can affect the baby. So it is very important to pay attention to what a woman takes if she's pregnant or nursing. So the route of administration of drugs can affect its concentration and dosage. So oral route's quite common. A lot of over-the-counter stuff there. Again, taken orally, you have to swallow it. It has to absorb. IV is going to be the fastest, obviously, because it's straight into the veins, so straight into the systemic circulation. IM is probably one of the next fastest, so it's injected into the muscle, and then from there it slowly absorbs into the systemic circulation. But I would say, really, other than IV, the other fastest is going to be inhalation, because anything that you can inhale into the lungs is going to cross over from the lungs straight into the systemic circulation too. So probably inhalation would be the most fastest after IV, but IM is really close on that too. So other routes are suppositories, especially if the patient might be intubated or have other things where they just can't do anything orally. And intraperitoneal, so like injection into the abdomen, if you will, or abdominal cavity. Topical, so anything on that's put on the skin, but you can also have like patches, so like the stop smoking patches, birth control patches, etc. And whenever you have topical, you want to limit the exposure of the same area of the body to reduce the side effects. Also, sometimes switching between the different routes can limit that exposure of the same area of the body to reduce side effects. Now, there are some drugs that are not available in oral formula, or they have limited formulas or routes of administration available. Okay, so if IV injection is the fastest route, then which one do you think is the next fastest? Which again, I just mentioned, so we have different choices here. You can think about that. All right, and so the drug levels, talking about drug levels, because that's what we measure in therapeutic drug monitoring. So the drug concentration will determine its effectiveness, and so the goal is to achieve therapeutic range, so having enough to where it's therapeutic but not so much that it's toxic. So again, a subtherapeutic dose then would not give the right therapeutic effect. It might not clear an infection or control a seizure, but then too much could lead to toxicity. So too much might clear that infection if you're talking about an antibiotic, but then might cause, renal issues, and that would not be good. Interestingly, anti-epileptic drugs, they can cause seizures whether the dose is too low or too high. And so it's very important for those to be right in the good therapeutic range. A loading dose is a dose that is given to help reach the therapeutic concentrations quickly. So not all drugs will have loading doses, but if they do, it's like a little boost, if you will, in the beginning, so we can get to therapeutic, and then you get the maintenance dose, which is much lower than the loading dose, and then it's taken on a steady schedule, and it can help reach steady level, which is where basically they're kind of oscillating as the drug is being given and cleared and given and cleared, but that oscillation is within that therapeutic range. So again, steady state, the amount of the drug entering the body then is equal to the amount leaving the body, and they are in therapeutic levels. The half-life of a drug is the rate at which the drug is cleared from the body. It is the time for the concentration to decrease by half. And so this half-life of a drug will determine the frequency of a dosage. So, for example, once a day drug like a birth control pill would have a longer half-life than a Benadryl that you can take every 46 hours. So the Benadryl clears faster than the once a day kind of birth control pill. So a therapeutic range then, of course, is the range at which the drug is effective, but it stays out of the toxicity range. Okay, so another application of half-life. So which one of these two over-the-counter drugs would have the shortest half-life? Would it be Claritin? Claritin is an allergy control medicine that you take once a day, or would it be Tylenol? Tylenol is acetaminophen, which is given every 46 hours. So that should answer that question for you. And a little bit about sample collection. So sample collection can be the trickiest part of therapeutic drug monitoring. And so it all hinges on proper specimen collection for proper interpretation of these results. So first you have to have proper collection tubes. It is very important to pay attention to what it says on the requisition slip. So some drugs level may require serum, some may require plasma, and some may say that you cannot use SST. And so the SST tubes are serum separator tubes. They have the gel. And the gel is at the bottom of the tube, and then you put the blood, and then when you spin the tube, the gel moves on top of the cells, and it separates the cells from the serum or the plasma. The problem with that is that there are some drugs that can be trapped into SST, and then they would yield a falsely decreased result if you use an SST tube when you were not supposed to. So some institutions will do peak and trough collections, especially on antibiotics. The peak would be the highest level, the trough would be the lowest level. And so usually what happens is they order the trough level first, and this is after the patient's had a couple of doses at least, and the trough level will be drawn like right before they get their next dose, so then their blood level would be at the lowest at the time. And then they get their next dose, and then the peak levels are usually drawn 30 minutes after an IV dose and 60 minutes after an IM dose and 2 hours after an oral dose. So that would be theoretically the highest amount. So where this is important to collaborate with the nursing staff, because what you have to realize is not only can lab draw samples a little early or a little late depending on what the workload is, but then of course nursing staff can also give the medication a little early or a little late. And so it's really good to communicate, like if you're going to go draw a peak, of a drug level on a patient, you might want to double check when that drug was actually given and if the right amount of time has elapsed. If you come in to draw a trough level, you might want to make sure that you haven't just given them, or that there's not a bag of the antibiotic that's still hanging and infusing, or they started it earlier and you were kind of later than when they thought you were going to be there. So a few other things that can affect drug distribution. So aging. So as a person ages, normally it's possible to see a decrease in GI function, which then means that less of the drug is absorbed. There is a reduced amount of body fluid, so they tend to be chronically dehydrated, and so therefore that causes increased plasma concentrations. There is a reduced ability to clear the drug because kidney function declines, and so that would also lead to an increased concentration. Pregnancy can also affect drug distribution. So nausea may affect absorption, meaning they can't absorb it because they're just throwing it back up, right? They have an increased plasma volume because they need more volume because they're dealing with 2 now. So then that would be more diluted concentrations of the drug. There's also faster removal of drugs, so the kidneys are being more efficient because they're processing more. So that would lead to lower concentrations of the drug. And of course, you also have to be careful because drugs can cross over the placenta, and you do not need to give teratogenic drugs to the mama. Those are drugs that could cause birth defects in the baby. So we're going to look at a little case for a second. So Marissa is 15. She was brought to the ER with severe shortness of breath. She has a history of asthma. She's been using her rescue inhaler, but it's not helping her anymore. So the physician administered theophylline IV to open up her airways. After about an hour, the patient begins to feel better, but then she becomes nauseated and vomits. She continues vomiting as the physician comes in. So he orders a theophylline level and a metabolic panel. So basically the theophylline level is 30. It should be between 10 and 20, so that's too high. Calcium is a little low, potassium is a little low. So all of this is probably related to what's going on here. And so do you consider this patient to have subtherapeutic levels or toxic levels of theophylline? So that should be a pretty obvious one there. And then next question, why did the physician use this drug? Well, it's pretty easy there. One, he switched the routes, right, from inhalation to IV type stuff or oral. I remember if theophylline is IV or oral, so he switched the routes. But also, because the rescue inhaler was not working, the albuterol wasn't working, there's no point in giving her more. It's not working, so let's switch up and do something that has a different mode of action. Next, we're going to get into some specific drugs. So we have cardiovascular drugs. They are in the categories that there are a lot of them used to treat arrhythmia, so abnormal heart rates. Many of them can affect the sodium-potassium pump, or they will affect sodium or calcium channels. Digoxin and amiodarone are frequently ordered, and so there's a really run-of-the-mill test for clinical chemistry. Quinidine and procainamide are infrequently ordered. It doesn't mean the lab doesn't do them, and they just don't do that many of them. And whenever a lab does procainamide, you also need to do NAPA procainamide or, N-acetyl procainamide levels, because that is the active metabolite. And those are the ones that actually are having the therapeutic effects. Not all drugs given to patients can be monitored. For example, both propranolol and verapamil are not available for testing by major reference labs. All right, so cardiovascular drugs, digoxin comes from the foxglove plant. It targets the sodium-potassium pump. It lowers heart rate, treats atrial flutter or atrial fibrillation and heart failure. Therapeutic range is 0.5 to 2.0, and if there's toxicity, you'll see GI and cardiac symptoms. Lidocaine is a local anesthetic and an antiarrhythmic. It is used after an acute myocardial infarction to prevent ventricular arrhythmias. It is a sodium channel target, and overdoses will cause central nervous system depression, or like a coma, if you will, and lower breathing rate and lower heart rate. Quinidine treats ventricular arrhythmias. It limits sodium ion influx, can be used to treat malaria too. The toxicity will manifest itself as vertigo, tinnitus, which is ringing in the ear, and headache due to low blood pressure. Procainamide treats ventricular arrhythmias. It is a sodium channel blocker. Therapeutic range is 4 to 8 milligrams per DL, and it's toxic at greater than 12, and it will depress heart activity. And you have to draw NAPA levels also with that one. Disopyramide is similar to quinidine. It blocks sodium channels. At high doses, it can inhibit neurons because neurons also need sodium to work, sodium channels, right? And it can cause hypertension and congestive heart failure if toxic. Flecainide is a sodium channel blocker. It is toxic to acute MI patients. There is a narrow therapeutic range, and toxicity of this drug will depress the heart, so cause hypotension, low blood pressure, and bradycardia, slow heart rate. Propranolol is a beta blocker, targets the heart muscles, and it opposes adrenaline. So adrenaline would make your heart beat faster and stronger. So propranolol does the opposite of that. So it lowers the heart rate. The toxicity can cause bradycardia, a low heart rate, and hypotension, a low blood pressure, and also cardiac failure. Amiodarone is a thyroid hormone analog. It blocks potassium channels in the heart. It is used in advanced cardiac life support for a pulseless VFib or VTAC. And therapeutic range is 0.5 to 2.0 milligrams per deciliter, and it has many toxic effects. Verapamil blocks calcium channels in AV node. It treats angina, hypertension, and arrhythmias. And when there's toxic levels, you see hypotension and ventricular fibrillation. Next, we're looking at the antibiotics. So we do not do TDM on all antibiotics, but there are some that are associated with severe side effects, but we also need them. Generally, the side effects are going to be nephrotoxicity and ototoxicity, so toxic to kidneys and ears, meaning in the ears it can cause deafness. Chloramphenicol side effect is usually toxicity to the bone marrow, meaning it can depress the bone marrow and cause you to not produce enough of your red cells and white cells. These drugs are typically drawn as trough and peak levels. The antibiotics, these are pretty typical, after usually 2 or 3 doses. And in order to properly dose the patients, these levels have to be drawn correctly. So again, collaboration with the nursing staff is essential there. Antibiotics can be bacteriostatic, meaning it's stopping the activity or the replication of the bacteria, but not killing it. But then it allows the body to take over and do its thing, the immune system to wipe them out. Or some antibiotics are bactericidal, meaning they directly kill the bacteria. Some antibiotics are broad spectrum, meaning they can target a wide range of different types of bacteria. And some are narrow spectrum, meaning they're only good and effective for a few different types of bacteria. These drugs must be used judiciously because we want to prevent antibiotic resistance, and that's a whole nother thing we're not going to get into. So in your antibiotics, the ones we monitor are really the aminoglycosides. They bind to bacterial ribosomes, and they have to be given IV or IM, so there's no oral formula for these, except for kanamycin. So amikacin is given every 12 hours, and all of these, as you'll see, are toxic to the kidneys and the ears, so it can cause deafness with prolonged use. Gentamicin is used every 8 hours. Kanamycin is the one that also has an oral version, and tobramycin is also a neurotoxic. Vancomycin will inhibit cell wall synthesis, so it's a different mode of action than these other aminoglycosides. It used to treat MRSA, but a side effect can be VRE, which is vancomycin-resistant enterococcus. It is also toxic to ears and kidney. Chloramphenicol is one that can cross the placenta and blood-brain barrier. Could be useful for meningitis, right? But it is toxic to the bone marrow. Your anti-epileptic drugs are anticonvulsants, meaning that they're used to control seizures. Most anti-epileptic drugs will block the sodium influx into the neurons that have damaged membranes. There are numerous anti-epileptic drugs available, and many patients take multiple drugs to control their seizures. Many of these drugs require a specimen to be sent to a reference lab to be analyzed. But the ones that are done commonly are going to be phenytoin, carbamazepine, and valproic acid. And so these are pretty much run-of-the-mill on your large chemistry analyzers or large immunoassay analyzers. So some of these you're going to need to know. So for sure, one recommendation is that you learn if there's two names to it, like a brand name and like the normal generic chemical name, that you learn both. Because what happens is a lot of times the nursing staff knows the brand name, but the analyzers or the tests are programmed as the chemical names here. So a nurse could call and say, where's my Dilantin level? And you need to be able to know that she's talking about phenytoin. Okay, so it's a good one. Those are good to remember. Okay, so let's start. We have phenobarbital is a barbiturate. It is a sedative. It binds GABA receptors in the brain, central nervous system here. It is used for anxiety and sleep also. It can develop tolerance and dependence. And when there's toxicity, there's central nervous system depression, meaning it can go into a coma. Phenytoin is known as Dilantin. It inhibits the sodium channels. It is not a sedative and toxicity with central nervous system depression. Valproic acid, also known as Depakine or Depakote, it inhibits GABA transaminase, and an overdose would be evident as a coma. Carbamazepine is Tegretol. It keeps voltage-gated sodium channels inactive. It is with mild toxicity, you see vomiting and ataxia, which is clumsiness. With severe toxicity, you see seizures and respiratory depression, meaning the heart rate, their respiratory rate is going to be low. And ethosuximide is a calcium channel blocker, and with toxicity, you see nausea, vomiting, and coma. With primidone, it metabolizes into phenobarbital and therefore binds GABA receptors in the central nervous system. Clonazepam is also known as Klonopin. It's a benzodiazepine related to Valium, which is diazepam, and it treats panic disorders. Gabapentin is also known as Neurontin. It is a chemical analog of GABA. Lamotrigine is a GABA antagonist, and levetiracetam or Keppra. We do not know the mechanism. This is one of those unknowns, and we know the toxic effects though are going to be a decreased red count, hematocrit, and neutrophils. And oxcarbazepine blocks sodium ion channels, and toxicity then will show hyponatremia. This is a little exercise of matching from my class because I want them to remember those. Next, we have the psychoactive drugs. So lithium is used to treat bipolar disorder, and testing is usually available in clinical labs using an ion-selective electrode or an immunoassay of some sort. Then your tricyclic antidepressants. These are actually often part of a traditional drug screen. Your drug screen immunoassay, those little cartridges, or sometimes run on the large chemistry analyzers. So usually if you want specific testing, you'll have to have high performance liquid chromatography or liquid chromatography tandem mass spec. And if you test for amitriptyline, you have to also measure nortriptyline. Most of the TCAs are going to be either norepinephrine or serotonin reuptake inhibitors, meaning norepinephrine and serotonin are two of your feel-good chemicals, neurotransmitters, or peptides that are floating around in your blood and your brain. And they're normally taken back up into the neurons, and so if they hang around longer, then they can have their feel-good effect longer. So of those, we have amitriptyline, which is known as Elavil, nortriptyline, desipramine, which is used to treat ADHD, imipramine, and diazepam, which is Valium, which is a benzo, and it's used to treat anxiety and insomnia, and it modulates GABA transmission. Next, we have the bronchodilators. They target the lungs, so this was for our case. So again, theophylline is used infrequently in adults, but it is used extensively in infants with apnea. In order to monitor the effectiveness of theophylline in infants, we do caffeine levels because caffeine is the active metabolite of theophylline. These are sympathomimetics, which means they are bronchodilators that don't raise the heart rate or increase the blood pressure. You have theophylline and aminophylline, and they're both used to treat asthma. And last, we have our immunosuppressant drugs that suppress the immune system. So they're often used to treat organ transplant rejection. So they're just automatically given for people to get organ transplants, but they're also used to treat autoimmune conditions. And most target cell-mediated immunity. So cyclosporine will inhibit interleukin-2, which then normally interleukin-2 activates your T cells. Mycophenolic acid is used in solid organ transplants, such as a kidney transplant or liver transplant, so solid organs, right? And it inhibits DNA nucleotide synthesis. Sirolimus is used in renal transplants or kidney transplants. It inhibits T cells. Tacrolimus is used in graft versus host disease prevention. So just a little note, if you don't know what that is this is when the transplanted organ is the immune system. So this would be like a bone marrow transplant. So the host has no immune system, it's been wiped out. We give it the host a bone marrow, the recipient gets a bone marrow from someone else. The risk is that transplanted immune system recognizes the entire body of the host as foreign, because it is. So obviously we want to close match that, but this can be used to try to prevent this graft versus host disease. And then lastly is methotrexate, which is a folic acid antagonist that will mimic DNA nucleotides. This one can be used in like RA and other things. So quick little matching thing for my students. And then there we go. We have reached the end. If you have any questions, just let me know. And I appreciate your time and attention. Have a good day.